A very healthy and hearty good afternoon to everyone out there. We're live here, right with you, and I'm back again, and this time with Dr. Bharat Bhosale, who basically needs no introduction. And today's talk would be on cancer screening early detection. I, Dr. Sadia from Medical Oncology, Clinical Associate to Dr. Bharat Bhosale. I'm here. I welcome Dr. Bharat Bhosale, who's also my mentor, and I learn every day from him. Thank you, sir. Thank you so much.
Thank you, Sadia. Thank you, everyone, for joining.
Though Dr. Bharat Bhosale needs no introduction, but here I am with a brief introduction about him for our new viewers. Dr. Bharat Bhosale is a senior medical oncologist with an extensive training and super specialty from Tata Hospital. Also, bone marrow transplant in charge, and further experience and expertise from USA, Zurich, Singapore, and Austria. Working passionately in cancer care since more than 15 years now. His area of interest being breast cancer, thoracic onco, gastrointestinal cancer, lymphoma, head and neck cancer, and hemat-oncology. So, as we proceed ahead with today's talk, the first question that comes to my mind is, and our viewers, would be what exactly is cancer screening? So, can you brief us about it?
Thank you, Sadia, for having me here. And as most of
Welcome,
you
sir.
are well aware, this is February month is the 4th February, especially is a World Cancer Day. And WHO, 25 years back, they started a campaign to educate people, educate the not only the community but the health, paramedics and the health caregivers. So this year, from 2025 to 2027, the campaign of World Cancer Day is united by unique. So
Yes.
every patient is unique, and we have to fight it unitedly to beat the cancer. Now, even after 25 years passed, and there have been many campaigns. Every year we come together to spread the awareness about the cancer. Yes, things have changed. The cancer has moved from no incurable disease to curable disease. Pediatric cancer, breast cancer are the best examples. There are many cancers, deadly diseases. The treatment used to be very expensive and complicated treatment like bone marrow transplant. Through precision oncology, we are treating those patients like hypertension and diabetes with simple pills. But the topic we selected today is early detection through screening. So why early detection, and then how to do screening? So we have to understand that any cancer, we goes through stages. That's pre-cancerous stage, early stage. That can be that can be stage 1, stage 2. Then it becomes locally advanced, stage 3, and sometimes early part of stage 4 in various organs. It depends upon which organ cancer we are talking about. So as I said, the cancer also has its own journey from early stages to advanced stages, from curative stage to palliative stage, where it can be cured. And based on what type of cancer we are talking, how it starts, how it spreads to other part of the body, depends upon the grade of the cancer and what are the causative agents. So you said why early detection and how to do screening. So early detection
And why
gives a.
early detection is important, yeah.
So as I'm discussing about the journey of cancer, so it's every time patient comes to OPD and the relative also are curious कि कब शुरू हुआ रहेगा ये कैंसर, कब शुरू हुआ रहेगा, right? That is the main question कि सर ये 6 महीने से था या 3 साल से था. And I mentioned about different cancers have their different journey. Some are very fast, develop from one stage to another stage, and some are very slow growing. Now this is very interesting. There are and then we'll come to the screening test. So suppose there are two people, and there is a cancer which takes years to move from one stage to another stage. Okay, suppose the person A comes to me and We do a test, we pick up in stage 1, we operate, and that patient will be cured, and we'll see him after 5 years and 10 years. The other person will come after 5 years, say, after the person A. Person B comes after 5 years. Maybe, his case also will be able to pick it up at stage 2, maybe, not stage 1. And you do your surgery or whatever chemotherapy, and then that person also is labeled as cured. But then at some time point in the future, say 10 years, you'll see that one person is living for 10 years and one person is living for 5 years. For any reason, if the cancer recurs, you will see that one patient has a survival of 5 years and the other patient has survival of 10 years. So this is something called as, for slow growing cancers. There are very slow growing cancers which by screening, and this is not very common, there is a possibility that you pick up those cancers very early. And there are other cancers which are spreading very fast. Okay. So in that case, if it spreads very fast, you lose that opportunity. And then it jumps into stage 4 where it becomes incurable. So two things are important. How fast the cancer is moving from one stage to another stage, so that you are not picking up by early detection so early. Yes, our intention is to pick in early stages, but largely we should pick up those cancers which, if undetected within span of a month, they can create a problem where you lose the opportunity to cure the patient. So this is something in a scientific language called as a lead time lapse. So your test should have the capacity to apply to large masses. When we talk about screening, it's not in patients, it is for a healthy individual. There are people who will come forward. They may not be harboring cancer or may be harboring cancer. So in a pool of common community, you have to take your test to a at-risk individual. Apply a test. Say for breast cancer, it's mammography. For lung cancer, low-dose CT. For cervical cancer, it's a pap smear. So apply to a larger population where you try and pick up cancer at pre-cancer stage or at the early stages, where your intervention as a surgery can cure it completely, de-escalate the treatment, bring down the treatment which is required in the form of chemotherapy, radiation therapy to a lowest possible level, so the side effects are reduced. So what you are achieving, you are picking up a cancer by applying a test in a curative stage, and by doing so you reduce the number of cycles of chemotherapy or number of treatment options the patient has to go in advanced stages to bring down them, so that the morbidity which comes out of the treatment also reduced. Now coming to a screening test, a screening test should be very what is the ideal screening test? It should be so simple that you should be able to apply to the masses. It should not be very expensive. It should be accessible to all, because I am thinking of a society which is a healthy society in which I am taking, and it should be feasible in the sense it should be carried out easily, and it should have a capability of picking up all the positive cases. Suppose I apply a test and I miss out, right? So that accuracy, so we call it as a sensitivity. For a screening test, be it a mammography, be it a cervical pap smear, be it a low-dose HRCT, or for prostate cancer, we do PSA, for colon cancer, we do colonoscopy. So the test which we apply for detecting cancer should have the capacity to detect all the cases which are carrying the cancer cells. So those all cases should be detected. So the risk of losing those patients, missing out of those patients, that percentage should be whatever minimal possible. So we calculate it as a positive predictive value and negative predictive value, sensitivity and specificity. So sensitivity of a test should be very high. When I choose a test in a statistical language, the sensitivity of that test, मतलब इसकी sensitivity इतनी ज़्यादा होनी चाहिए कि we should not miss out those cases. The false positivity should be less. You should pick up all the cases. The false negativity. So we should apply a simple test, which is not very expensive. We should pick up all the cases in the community. Okay, so that is called as an ideal screening test. Now coming to breast cancer, we have mammography.
Yes,
It's a
specifically in relation with cancer.
So the advantage of and this is all through a scientific research. It's not something somebody has innovated this machine and applied. So for breast cancer, for cervical cancer, for prostate cancer, for lung cancer, so these colonoscopy or sigmoidoscopy, these tests are actually studied in a bigger community studies, scientifically done studies, where they have seen if you do this test and you pick up a cancer and you treat that, it actually translates into survival. So what I was trying to tell you, if you do a test, you try and pick up cancers in very early stages, but the cancer speed might be very low, so that you are actually picking it up way ahead and showing that the patient is living longer. That is not happening in these cancers. Means all these interventions which I mentioned are actually useful to the community, and it is studied and tested in a scientific way. And that is how now they are a part of the guidelines in many Western countries, that the government has no time points where all these tests needs to be done, because it is scientifically proven they are helping people.
So,
Got it?
this with
I
yes,
hope
sir,
you got
yes,
it.
sir,
It is more of a statistical point of view. I tried to explain it, but these tests
yes, sir.
now we recommend because it has been scientifically studied that they do help people.
Yes, sir. No doubt. So the thing that comes to mind is, when do we know, when our viewers, they know that what is the right time when they have to go for certain screening related to certain cancers, like for colon, for breast. What at what age they have to go, and when do they go?
Sure.
Where do they go?
So very important point. So as I told you, if we want to pick up them early, means it should not spread to other parts of the body. Say colon cancer, when no, most of the time we don't do colonoscopy in our country routinely. Even educated doctors don't do it. Okay. So to miss out those spread to liver or other organs, when we label them as a palliative or non-curable, there are certain guidelines which comes largely from Western countries, and we review it and we adapt in our guidelines, India specific guidelines. So for breast cancer, which is one of such kinds where early detection helps to cure up to 100%. If you pick up in pre-cancer stage, there are something called as a pre-invasive cancers or DCIS or lobular carcinoma in situ. Even beyond that, there are stage 1 cancer. If you pick up in breast cancer, the cure rate goes beyond 95%, right? Same cancer, if you miss and it goes to stage 4, the cure rates become very low. Stage 4, the cure rate is 0%. But in stage 3 also, your cure rates are not above 50% in advanced stage 3. So in breast cancer, usually guidelines for no India specific region, every woman after the age of 50 ideally annually should go for the breast cancer screening in the form of mammography. But it may not be feasible to all. The best screening is self-screening, which is called as a breast self-examination. Every month at a specific time point on the day of period, the menstrual period, self-breast examination. There are videos where no self-breast examination inspection and clinical palpation can be done by the females themselves. And if any suspicious findings are there, like lump or bleeding from the nipple or some skin changes, so there are specific changes which occurs in the breast, which are physiological, and there are specific changes which are related to no alarming that it can be cancer. So then they should go to the clinicians and get it examined. Ideal screening test, what I was describing, is a mammography. It's an X-ray done in a specific way where you can actually pick up these lumps. And there are various ways. It can be seen as a marks over there or a calcification, irregular margins. So then a high volume radiologist can pick it up and do the biopsy to confirmation. But the ideal screening test to detect breast cancer in early stages is mammography, and which ideally should start at the age of 50 to 60 age group. It gets the maximum benefit. Now what happens to those patients who cross 60, 70 and no beyond that? So if those patients who are doing regular mammography after the particular age in the elderly group, you can reduce the frequency of doing it, and you can stop also at the age of 70 or 75. Then what happens to younger patients? Below 50, the breast is actually dense. You may not see those lumps on the mammogram. So you can add to sonography to that. But If somebody has a family history and somebody is carrying a genetic mutation which increases their risk to develop breast cancer manifold as compared to the normal population. So there are particular genes which are defective in less than 5% of the familial breast cancer cases. In those cases, the screening should start very early. Maybe is based on the at what age a family member has developed a breast cancer in the family. That is very important. So your screening of a normal healthy relative should start way before that. And in that case, more than mammography, it is the MRI, breast MRI is required, because mammography cannot pick it up. So there are certain guidelines. People with family history or carrying genetic mutation should consult an oncologist and decide their plan. But for large population, it should start at the age of 50. If somebody feels that they need to do checkup based on the family history, from 40 to 50 also it can be done, but it largely has to be a sonography in addition to the mammography, which is a X-ray. Now coming to the pap smear, cervical pap smear, there are certain guidelines. Now a lot has been talked about vaccines. People are aware. There are many people from the metros are going for HPV vaccination. The cause for cervical cancer is human papillomavirus infection in majority of the cases. And if you prevent the infection of human papillomavirus, ultimately the occurrence of pre-invasive cervical cancer and then invasive cancer over a period of 2 or 3 decades goes down. So one intervention is to apply the get the vaccination shots. But remember this line: in spite of taking the HPV vaccination, there has to be a proper screening to pick up the cervical cancer in early stages. Because vaccination will prevent only the infection of HPV vaccines. The screening.
So when the vaccination to be done.
Vaccination, usually the age group is 9 to 23, and after the age of 9 and up to the age of 23, they are extending that age also beyond that per case. You can personalize that. But in spite of taking vaccine, the screening has to be there. Because in India, in Dharavi, in Mumbai, they have done a study of simple application of the colonoscopy examination of the cervix is basically the part of womb, the entry point of the womb, and the cancer happens there. It can be picked up in precancerous stages where the cure rate can be 100%. It can be picked up in stage 1 where the cure rate can be beyond 98%. But screening is important. Even in those who have taken vaccination, screening is important. And actually, screening for cervical cancer ideally starts 2 or 3 years after starting so it can be somewhere from 21st, 21 to 22 or 23. Once the sexual activity starts, it should be within 2 or 3 years, right? So you have to start at regular intervals, maybe bit annually or once in 2 years. The regular examination has to be there, which is called as cervical pap smear. Now there is a specific test called as a HPV virus can be picked up by certain tests. So you take the smear from the cervical parts of it's the upper end of the vagina. From the gynecologist or the preventive oncologist, take the scrapings, and that goes for the testing. So if there is a negativity for human papillomavirus, then you can extend the period up to 5 years. But a simple smear where you can see actually the dysmorphic cells or cancer cells, then it has to be annually or once in 2 year regular intervals. That means it is not only once, it has to be a periodical thing. And then if it is persistently coming negative for many years, then you can decide upon when to stop. So as I mentioned about the study in Dharavi, they have looked at a simple way of doing these scrapings and taking this for examination on the smears. And that had shown that you can actually save 40% of the lives. Means a simple intervention, which is an ideal screening test, which is not expensive, which is accessible to the community, and it can be done by trained paramedic staff. You don't need only the senior most doctor going over there. If you train a staff properly, they can do. Because see, in India, we have to understand our low and middle income countries, you have a scarcity of expert staff over there. So simple test which can be done for a large mass, which is not very expensive, can reduce the death rate by 40%. Is I feel that is one of the ideal test which we have. But see the usage, hardly anybody is using it. So that is what is required. We are united, but unique ways you should uniquely utilize which are preventable things. Sorry, you know how much patient do suffer when the cancer goes the advanced stages, right? And here
Yes.
are some interventions which are inexpensive, can be done easily, can cure the cancer up to
Exactly.
100%, right? So
True that.
this needs to be told. This needs to be told, to everyone, because I feel all these facilities are not being utilized. So this is about,
Right.
especially for females, for cervical cancer and breast cancer.
So, are there any risks involved with the cancer screening of different
So
cancers?
largely, there are no risk
Fine.
involved because these are not done by trained people. Um, Risk in the sense mammography is a little bit painful, but no, after counseling, patient can tolerate that. I don't think even cervical pap smear is also simple thing. It's not associated. The only thing is, we used to scientifically study whether by detecting early, are we detecting more cases in lung cancer. I would say we are not using low dose CTs to detect the cancer early, but in Western countries, it has shown that if you do low dose means it's the exposure to radiation. If you do low dose radiation for the at risk population, those who are smokers or who are in contact with smokers, which we called as a second hand smoking, in those cases, if you target doing these low dose CT scans, you end up in picking the lung cancer, which is actually a deadly cancer. In 85% of the cases, those who come to us are in advanced stages where the intention of treatment is not curative. So only 15% of the cases we are able to operate or give chemoradiation in the form that it's a curative therapy. Why this happens? Because by the time the patient becomes symptomatic, by the time patient shows some symptoms, the cancer has gone already into stage 3 or stage 4. And that is the ideal goal for a screening test to intervene. That patient is not symptomatic. Those patients, those people from the community we go to are not showing any symptoms. Still, we apply a test to pick those cases in early stages. So in lung cancer, I'm telling you, 85% of the cases already we come to us in the last stages where we can't cure it. So if you apply this particular test in healthy people, you can pick up in lung cancer in very small form or small nodules. But challenge here comes that you have to do a biopsy. Then it's become an intervention. So you must have basically a very good trained high volume radiologist who can tell 100% that this could be cancer. We should have intervention radiologists who can actually biopsy it, and then you should have a high volume pathologist. We can look at it and tell us that it is cancer only. So when you do a simple scan and you get a nodule, it can be cancer or not cancer, right? And to prove that,
Yes.
you have to take a decision first of all whether it's a cancer or not. Second thing, whether to biopsy it or not, and then you have to tell on the biopsy that it's cancer. So your the backup staff, the resource should be highly trained. Otherwise, what will happen? I will do a CT scan and everybody will go for biopsy. And lung biopsy is not a simple thing. So one of the drawbacks of the screen test is over diagnosis or some over no over. There are putting up the patients are putting under various tests. So if you have an excellent or highly trained or a high volume physician, radiologist, pathologist, then this risk can be minimized. So this is for lung cancer.
Yes.
Rest cases, it is very, this none of these tests are so invasive. They are they can be done superficially. Though they are tests or invasive tests, they are not that invasive because in the lung you have to put a needle inside the lung and to reach out to the nodule. But largely in India, we are not going for low dose CT scans because in India now we are seeing more and more non-smokers are developing lung cancer, and that is because of the second-hand smoking. So rather than going for this option, I would urge that reduce the smoking so that you reduce the second-hand smoking. Those who are not smoking will get no less exposure to smoke. In rural areas, you have exposure to the household no pollution which is coming up from combustion of various materials. So if you reduce that, the number of lung cancer cases will go down. So in lung cancer, I think prevention is better than even better than early detection. Yes, early detection also picks up those cases early and gives us a chance to cure. So this is about lung cancer, Sadia.
Mm. So, for example, there's a 30-year-old couple, a male and female. Now they have decided they have no idea about cancer screening, and now they've decided they would go for a cancer screening for the male and the female at regular intervals or whatever time, whenever it is required. So, how do they know? How do they know when, like, she has done a breast screening examination at 35 year of age? Now, when she has to do, or
So,
the mail when he has to do, and what he has to do, how do they come to know the authentic information? How do they receive?
so Sadia, so in our country, as you know, we have large number of population where the doctor population ratio is very less. Ideally, when you have a screening test available, there has to be a pre-test counseling and a post-test counseling. Means when we do no genetic test, we do pre-test counseling. Likewise,
Yes.
somebody approaches for screening, they should be counseled. They should be counseled that these are the tests available. Ideally, who are the candidates, to do these tests. So if you fit into that, you should definitely do it. Like you are asking about 30-year-old female who randomly comes to me and tells me, no, I want to do screening. If she doesn't have any high risk behavior in the sense or high risk family history in the form of there are no cancer in the family or probability of any genetic mutation carrying is very less, there is no need to do a
Just like at what times in life she should be screened,
yeah,
like
yeah. So that's what I'm. So a screening
yes.
pre-test screening is very important. Whether qualify for that test, and if the result comes positive, you don't have to worry about it. It will be detected in early stages and it will be curable. So it reduces the anxiety to undergo this test. And then if the test is done, irrespective whether the test is positive or negative, the patient should undergo post-test counseling. Now, for a young couple, if they want to do screening, and if they don't have any history, for a female, the ideal mammogram should start at the 45 or 50. Now, we see in India, people are developing breast cancer 10 years earlier as compared to Western countries. And we usually follow the Western countries' guidelines. So, we have to have India specific studies which are not there largely. No, there are studies from South, and there are some studies, as I mentioned, in Dharavi for the cervical cancer, and mammography studies are also there. But in a younger patient, to apply a breast mammogram is difficult, or interpretation of a breast mammogram becomes difficult because of the dense breast. So ideally, a mammogram should be done after the age of 48, 49, 50. So that's the postmenopausal age group in the India. And younger patient, if still they want to do clinical examination, self-breast examination followed by clinical evaluation at suspicious is the best way. The screening should start at the age of 48, 49, 50. For those patients with a strong family history, yes, they need a pre-test counseling, and MRI is the ideal way to do to do a breast screening, not the mammography, or a combination of sonography and X-ray mammography. For males, as I mentioned, colonoscopy, and there is something called the prostate cancer, which can be picked up by doing simple PSA test, which is a blood test, and digital rectal examination done by urologist. That can pick up. Again, prostate cancer is a cancer of old age, like it happens at the age of 60, 70 years. If I start doing PSA of hundreds of patients and it comes positive, because there are normal conditions like infection of the prostate, which is very common in males. That also leads to increase in PSA. So if you do PSA and if it comes up, everybody will have anxiety. So that is the importance of doing a pre-test counseling. Even if something comes positive, don't worry. We have just done a screening test. That does not mean you have cancer. You have to undergo a second test, which is called a biopsy for confirmation. And that also one has to examine clinically and then decide. That's why for prostate cancer in male, it usually should be done after 50 or 60s. And those patients with a strong family history should consider doing it before that. Colonoscopy gives a chance to pick up the colon cancer in first stage, wherein if you miss, it can go to liver and lung, and then things become non-curable. So
Yes.
colonoscopy is also done on OPD basis. Yes, it is an intervention, and for that it requires special preparation. But it gives a chance to pick up the cancer in precancerous or stage 1, where it can be completely cured. So, as I mentioned, breasts, mammography, if required, MRI. Then you have pap smear, simple pap smear where you just look at the nature of the cells. And if you do HPV tests, these are specific tests. It gives us chance to pick up. No, again, you can reduce the number of visits, or you can extend interval between the two tests. That is for HPV testing. Again, for the cervical cancer. Third thing we mentioned about the low dose CT for lung cancer. Then we talked about colonoscopy. Then we talked about prostate cancer. In colon cancer, there is another test called as the fecal, simple stool for occult blood. We, if somebody wish to do it, they can do annually. Just stool examination where if there is a bleeding in an entire GI tract, the red blood cells are seen in the stool. So that can be because of normal ulcer also, but it gives a chance to pick up those cases for colonoscopy. Or if colonoscopy becomes normal, you can do upper GI-scopy. We can pick up stomach cancer cases also like this. But for stomach, it is not recommended, but it is a simple test. See, again, ideal test, which is not expensive, doable by everyone, and you select those cases which are positive and do the intervention in the form of colonoscopy in those patients. Also gives a chance to pick up cancer in early stages where it can be cured up to the tune of 95 to 100%.
Yes.
Sorry.
So what should be the next step when the screening comes out to be positive? Like, the screening comes out to be positive, the patient is panicked. What exactly should be the very
So,
next step?
so let's talk about breast cancer. Somebody has done a mammography and the film shows the report is actually there are grades. BIRADS 1, 2, 3, 4, 5, and 1, 2, 3 largely towards benign, and the 4 and 5 are towards the malignant. But again, if screening test shows something, you have to inform the patient not to worry. Still, there are chances, it can be positive or negative. So then you have to take it to a test. I talked about something called as sensitivity and specificity. A screening test should have a highly sensitive. It should not miss out those positive cases. When it comes to confirmation, your test which we apply is a biopsy. There should be 100%. It should give proper results. So you have to confirm it. So you counsel the patients. Yes, your screening test has come positive, but 99 to 100% of the cases we end up in picking up the cancer in stage 1, and then it is curable, completely curable. Because once the screening test comes positive and the patient is not counseled before this test, patient will develop a high level of anxiety. And in my practice, I have seen the fear is the biggest factor to hide the disease. You must have seen the people are coming with the big lesions in the mouth. They keep on hiding. You must have seen the people coming with the fungating wounds in the breast. See, this is what the real life scenario you have seen. We have seen in our clinic, right? People come with the big lesions, and you go Western country, proper screening is applied every year, and their tumor sizes are like few millimeters, 5 millimeters, 7 millimeter. Yes, in India with no proper awareness, people are coming forward, and we are also picking up these cancers in early stages. Now, imagine a tumor which you picked at 5 millimeter or 1 centimeter, and imagine you are on the other side, you are seeing 15 centimeters, fungating wounds, bleeding wounds. You can't cure those, and that is the goal of screening. That is the goal of screening, where it gives an opportunity to every individual and healthcare worker to increase the success rate. Yes, we prevent these cancers to going into stage 2, stage 3, stage 4, and that is the beauty of screening. And it is tested.
Here
It is
comes
time tested,
the,
scientific. Yeah, yeah.
here comes the role of and benefits of early detection.
Yeah, absolutely. Now, I see these are the examples, which we can tell, and that is how we can tell, because screening, sensitivity, specificity, positive predictive, these are scientific words, and as I said, these have been tested scientifically. Now we have to use it, because it has shown that using these tests, what we mentioned, it cures by detecting early, and the cure rate can be up to 100%. But if you go to next stage, your chances of cure goes down by 10%, 20% with every stage.
So with this, because we are a little out of time, if we can get to the,
So we're
it was
finishing.
superb,
Acha, we are
enlightening.
finishing.
Yes, sir.
We are finishing.
Yeah, we are towards the end of it. We are
Oh,
running out.
I
So,
realized.
yeah, it was so enlightening that we could not register the time. So, if we can get the takeaway message from this talk, a takeaway message for our viewers.
So, Sadia and all the viewers, the cancer incidence is increasing. Maybe no, there are many factors: the lifestyle, the kind of no environment we have, the kind of food we eat. But it's not like no decade back. We are curing cancers, and the best way to increase anybody's chance to cure is by picking up early. Before the cancer shows its symptoms, you have healthy checkups. People do ask for various checkups. So cancer screening tests, get aware about what cancers can be detected by early screening. We discussed few of them. Go regularly, judiciously follow those steps, and by early detection, I can assure you, you can beat the cancer, and the cancer cure rate can go up to 100%. But you have to be sincere for you, your family, your friends. That's it.
Yes, sir. So true. Thank you so much, sir, for this the enlightening talk that we had today. And for any further queries, I would like to tell our viewers, sir is available at SL Rahija Hospital, Mahim, which is a Fortis associate. Please contact at the earliest of your queries or any symptoms, alarming signs that you see. uh, so with this, we end the talk, and it was wonderful having you all here. So thank you so much. Thank you so much for your
Thank
valuable
you.
time.
Thank you.